Well, I must say I'm feeling very impolite at the moment, because normally I will respond to all of the emails and all of the comments that are left, but there's been rather a lot lately, and with other things I have to do in the day, I haven't had time to get back to everyone yet. So my apologies if I haven't got back to you yet. I hope to do so. Now, in these videos, we're taking an approach which is evidence-based, as we've said. Now, in the last video, we did mention how long things survive on surfaces, and I said 5 to 28 days. What this should say really is 0 to 28 days, because we often say 5 days is kind of a time we would expect things to survive. So really it should say 0 to 28 days. So some things should only survive for a few hours or less, or a day or 2 days or 5 days or up to 28 days, depending on the conditions. And we looked at the different conditions in the last video. Do catch up on that if you would like more information. Now, another really common question I get asked is, if someone gets the virus, or if I get the virus, how likely is it to kill me? So the British medical officer, chief medical officer, is still saying 2% of patients are dying from this condition. We don't know. That's what we're still saying there at the moment, because that's, when you look at the evidence base, sometimes you're looking at empirical evidence, like we always try to do, like we'll be looking at in this paper here. Other times we just have to settle for expert opinion. That's not me, I hasten to add, but the chief medical officer of my country hopefully is an expert opinion, so we're going with his evaluation at the moment. It is consistent with the literature that I have analysed, and we don't have any more up-to-date evidence base, so we'll stay with that. So what we want to look at here is the probability of dying if you get the infection, and what factors determine the mortality in novel coronavirus infection. And fortunately we've got a paper on this. It's been published in December 2019. The data was actually collected, the work was actually done in Shanghai. So predicting mortality risk among patients with viral pneumonia. Now we've said that there's some things we know about the novel coronavirus, and there's some things we don't know. There's a lot of things we don't know. So what we're trying to do to give ourselves a bit of a heads up to prepare for this coming epidemic, or what I fear is going to be a pandemic, is sometimes, because we haven't got the specific knowledge on novel coronavirus, we have to sort of take from the next best thing. That's studies on other coronaviruses, as we did in our study of MERS and SARS, for example, in the couple of 2-3 videos ago. And here, this study is on viral pneumonia generically. Now, viral pneumonia can be caused by different viruses. Corona is certainly one of them. And there's no reason to think it's a particularly atypical viral pneumonia. So, predicting mortality risk among patients with viral pneumonia in Shanghai. This was published in Frontiers in Microbiology, December 2019. So, viral infections could present with severe pneumonia leading to acute respiratory distress syndrome. So what do we mean by that? Well, as we've looked at several times now, we have the alveoli. This would be what you call a respiratory bronchiole, one of the terminal bronchioles, leading to these large air sacs like this. There's also smaller air sacs on the respiratory bronchiole like that. And there would be another one here, small alveoli leading to these big clusters of air sacs like this. And then this would derive from what we call a terminal bronchiole. So the bronchioles are the microscopic air passages. The alveoli are these they're described as hollow bunches of grapes sometimes. These clusters. And what they do is they give a very large internal surface area. So what this means is the internal surface area inside the lungs, if you were to open all these alveoli out, if you're young and healthy, There's about 100 square metres over which gaseous exchange can take place. So the oxygen goes to so the capillaries are going to be very close to here. There's going to be capillaries. Blood's going to come in from a branch of the pulmonary artery via the pulmonary arteriole, deriving from the right ventricle of the heart. Blood's going to leave via a pulmonary venule, and the pulmonary venule is going to drain into the left atrium. So when the blood arrives here, it's going to be low in oxygen but high in carbon dioxide. And when it leaves here, it's going to be high in oxygen but low in carbon dioxide, because the carbon dioxide is going to go that way and the oxygen is going to go that way. That's the whole purpose of this, these structures. But that's healthy, that's physiology, that's good, that's normal. So viral infections can present as a severe pneumonia. So pneumonia is infection at the level of the alveoli. So if we think of the main bronchus there, the trachea there, that's going to divide into the right and left main bronchus. This divides into numerous smaller, progressively smaller bronchioles. And this looks like all these little branches, they look a bit like a tree, so it's called the bronchial tree. Now, if there's an infection in the trachea, that would be tracheitis. If there's infection in the bronchial passages, that would be bronchitis. Actually, itis technically means inflammation of, so other things can cause inflammation as well. But pneumonia and acute respiratory distress syndrome is pathology at the level of the alveoli down here. So what happens, let's think about pneumonia first of all. So in pneumonia, there's infection in the lung tissue. So of course these structures here go into the lungs like this. They're going into the lungs. Two separate lungs like that. And these get smaller and smaller and smaller till eventually they get to terminal bronchioles, microscopic scale, right down to the alveoli, which you couldn't, of course, see. They're microscopic. So that's what's happening. So bronchitis is at the level of the bronchial tree. Bronchitis. And bronchitis, you get a cough and you cough up lots of sputum over a period of time. That would be bronchitis. Most common cause in my country was smoking and smoky environments. So in pneumonia, it's not bronchitis. In pneumonia, the infection is at the level of the alveoli. And what happens is when you get infection is you get inflammation. And these blood vessels will dilate. You get dilation of the blood vessels. And that makes them leaky. And fluid gets out. So inflammatory fluid gets out and fills these up. They become consolidated. That's pneumonia. And of course, I think that's fairly obvious that you can't get the oxygen into the blood and you can't get the carbon dioxide into the alveoli to breathe out. So that's clearly a problem. Now, the difference with acute respiratory distress syndrome, we've called this different things at different times, but now we call it ARDS, acute respiratory distress syndrome. This is caused by inflammation in the alveoli here at this level. Inflammation in the alveoli. Now, this inflammation can be caused by infection, but it could also be caused by inhaling noxious gases. It could be caused by direct physical trauma. So anything that causes inflammation down at this level here. So there would be inflammation at the level of the alveoli. This would be inflamed. And as we've said, the inflammation will result in dilation of the capillaries, making them more leaky and fluid will come out. So more fluid will escape from these capillaries that are surrounding the alveoli. Fluid will escape, and this fluid will, first of all, it will collect here. That's bad as well, because that means you've got a fluid layer between the blood and between the fresh oxygen. So that inhibits the diffusion. But over time, the inflammation will fill these up as well. So the end result in ARDS is very similar to pneumonia. You get clogged up alveoli with water, and gaseous exchange is prevented. The oxygen can't get in. If the oxygen can't get in, that's called a hypoxemia, a lack of oxygen in the blood, a hypoxemia. And of course, the reason we need oxygen in the blood is to get oxygen to the tissues. And if there's a lack of oxygen at the level of the tissues, that is called hypoxia. And it's been said that hypoxia will first stop the machinery, then wreck the machine. And the brain is most sensitive to oxygen. So if the oxygen levels drop, the brain will stop working, it will stop the machinery. Then over time it will wreck the machine. The brain will be permanently damaged by the hypoxia, as indeed will all the other organs of the body. So hypoxia will first stop the machine, then wreck the machinery. So if we can't get the air in and out of the lungs, it's a life-threatening situation. So that's why these conditions are so dangerous. And bacterial infections are a common complication. Now, what's happening here? So what happens here is lining the respiratory tract, we have respiratory epithelium. So let's imagine this is one of the bronchial passages here, like this. And what we have on the surface, we have these column-shaped cells, usually like this. This is the respiratory epithelium, the lining of the respiratory passages, often column-shaped epithelial cells like this. And very often they have these microscopic hairs, hundreds of these microscopic hairs projecting from the surface, the cilia. And the job of the cilia is to waft up the mucus. They waft like this. They waft up the mucus. They waft up the mucus. And they waft the mucus up towards the trachea. Then it can be coughed up over through the vocal cords, up into the back of the mouth, into the oropharynx. And you can decide what you want to do with it. You can spit it out or you can swallow it. It's up to you. So this respiratory epithelium lines these respiratory passages like this. Untold millions of columnar respiratory epithelial cells. Now what happens is, when a virus gets into a cell, so let's imagine that this is an individual respiratory cell here, and you get a viral infection in that cell. So we now have viral particles in that cell. Now, the cell is able to excrete some of these viral proteins onto its surface, like that, onto the surface of the cell. And it does this so the cell is now communicating with the outside world, well, with the outside internal environment of your own anatomy and physiology. And it's saying, I've got a viral infection. I've got a viral infection. And then a particular blood cell called a killer T cell, the large T cells, a big killer T cell will come along. These large killer T cells. Great name. They're called NK cells. Natural killer cells. And the NK cells, the large lymphocytes, are not that specific. They will attack a wide range of infections. So here what happens is the cell recognises that there's viral particles on the surface of this cell. Can't see into the cell, but it recognises it because the cell's cleverly exported viral proteins. So the NK cell, this large lymphocyte, recognises it. Now, the viral particles are multiplying inside the cell. They've hijacked the cell's genetic apparatus. And they have to do that because the viruses can't, the virions, the viral particles, can't reproduce on their own right. They can only reproduce by hijacking the protein synthesizing apparatus inside the cell. They are obligate intracellular parasites. They can only live inside the cell. And the natural killer cell can't get in there. So what it does is it drops chemicals on this cell, just kills the whole thing. Kills the whole cell. Just kills it. Drops poisonous chemicals on it, makes holes in the membrane, cell explodes, cell Cell dies, cell fills up with fluid, cell dies. It kills the cell. Now, this might sound a bit strange at first, but if the natural killer cell had not killed the respiratory epithelial cell, then this would have gone on and produced hundreds or thousands of more viral particles. So imagine that was the infected cell there, and it had produced hundreds of thousands of more infected particles. This would have gone on and infected more and more cells. Just one virus gets into the cell and that can multiply up to hundreds of viruses inside the cell, maybe thousands inside the cell, and you get a rip-roaring infection, much more serious infection. So it kills the viral infected cells. It's a bit like you had a group of terrorists inside a room, and someone in special forces comes along and throws a hand grenade in the room, just takes out the whole room. So yeah, it's going to blow up the room, but it's going to kill everyone in the room as well. And it kills the virus. That's the way these things work in the initial stages of the infection. But what that means is that the natural killer cells might have killed that cell, and that one, and that one, and that one, and that one, and that one. They've killed a lot of cells. So now it's a bit like there's gaps in the rows here. There's a distorted, non-normal anatomy. There's inflammation because these are dropping chemicals on the virally infected cells. So there's going to be inflammation, and as well as that, there's going to be physical gaps. And normally, of course, there's a layer of protective mucus on the surface here that's wafted along the surface of the cilia. And that layer of protected mucus can be disrupted as well. And what that means is that opportunistic infections. So normally bacteria will be breathed in here. Of course, there's bacteria everywhere. They'll stick to the mucus and they'll be wafted up in the mucus, and you'll just cough them up. You'll get rid of them. They'll be normally coughed up in what's called the mucociliary clearance system, and you'll excrete the virus just coughing it out, hopefully into a tissue, hopefully into a bin. That's called catch it, bin it, kill it. We don't want to blow it all over the place, spreading infection. But now these cells are dead. So what this means is there's an ecological niche here for these cells to get in. So normally they couldn't get in, but now they get in. So these cells get in. They're opportunists. They take advantage of the opportunity that's been given, and they colonize this vacated ecological niche, and they multiply. And what that means is you get secondary bacterial infection. And this is a very common problem, secondary bacterial infection. Now, I have been asked this question quite a few times. There's been people that seem to have be recovering from the novel coronavirus, and then they seem to, a few have died all of a sudden. There's one in the Philippines, for example. Well, it may be this that's happened. They've developed a severe, overwhelming secondary bacterial infection. So that's why when we looked at the American study, the patient was actually given antibiotics, even though he may not have had a bacterial infection, to guard against the possibility of secondary bacterial infection. Because we know that viral infections of the respiratory tract can be complicated with secondary bacterial infections. So that might have been a cause of death in people that were recovering. Having said that, there might be viral causes for those deaths as well. We simply don't know that yet. So that's sort of the pathophysiology here. This is what's going on. This acute this situation where the alveoli are filling up, the pneumonia leading to acute respiratory distress syndrome, with the possibility of bacterial secondary infection. Now, in this study in Shanghai, there was 529 patients, which is quite a reasonable number, with viral pneumonia. And of these, 14.4% died within 90 days. Now, this is somewhat similar to the limited amount of data we have on the novel coronavirus, because we know from the study in The Lancet on the 29th of January that 11% of patients who already had pneumonia as a result of novel coronavirus died. But that was in a fairly short time span, whereas this went on for quite a few weeks. So it looks like If we studied this cohort up for a bit longer, maybe 1 or 2 might unfortunately die as well. So it looks like, given this limited data we have, the rate of death in novel coronavirus is similar to the rate of death in generic viral respiratory infections, which was about 14.4% in patients with viral pneumonia. Bacterial pneumonia, of course, is also a massively dangerous condition, and people used to die of it. In fact, people still do die of pneumonia, of course. But the difference is now we can treat the bacterial forms with antibiotics. It's still dangerous. It can still cause sepsis, and we need to give that antibiotic treatment as quickly as we can. But we at least have that possibility. So this Chinese group worked out, what they did was they took these 529 patients with viral pneumonia, and they looked at their state of health, and they looked at their past medical history. So, for example, they looked if they had heart disease or ischemic heart disease or other things like that, and they looked at these things. And what they found was that things like ischemic heart disease and heart failure and diabetes actually didn't make a difference to the mortality, which was surprising. These were the things that made a difference to the mortality in terms of statistical significance. These were the things that made a difference. So the first one is multilobular infiltrations. Now, a pulmonary lobule is the alveoli and the respiratory bronchioles beyond the level of a terminal bronchiole. So this area here, perhaps with about a dozen other alveoli, would be a lobule. So if there was diffuse disease, in other words, if lobules in different parts of the lung were infected, that would be a problem. And that would give a score of 5. And the higher the score, the worse. Now, we've noted that in viral pneumonias, and consistent with this, we've noted that in novel coronavirus pneumonias, from what we know, there's often a reduction in the number of lymphocytes. So the leukocytes are the red cells, are the white cells, the erythrocytes are the red cells. The leukocytes are the red cells. The lymphocytes are the type of red cells that particularly fight viral infections. And pneumonia means lack of. So it's been noted that in some of these patients with novel coronavirus, as in these patients with other types of viral pneumonia, that the number of lymphocytes goes down. Probably because the infection is affecting the bone marrow and the production of these cells. Probably because the virus is directly affecting the cells. It's a real battle, this. It's a real battle. But lymphopenia is associated with a score of 4. Bacterial co-infection, as we noticed there, if there's bacterial co-infection, that's a score of 4. And then smoking history. So can you see we've got MU multiple. L, B, S, T for tension and age. Can't even say that. Muloblaster, I'm not sure. Anyway, this is the score. And they did find that this worked. So current smokers scored 3. Former smokers scored 2. And surprisingly, diabetes, heart failure, asthma, chronic bronchitis didn't seem to make a difference to the mortality rates in patients with viral pneumonia, which is really quite surprising. But they didn't find a statistical correlation there with a 95% certainty of being correct. But they did find one with hypertension, and they did find if people were 60 years of age or older. So what they found was you can add this score up, 5 for that, 4 for that, 4 for that, 3 for that, 2 for that, 2 for that, 2 for that, add that up. And they thought that score of 0 to 11 was low risk of mortality. Patients with 12 or more had a high risk of mortality. And when they followed them through, that's exactly what they found. I've got a piece of paper I've lost here, but never mind. So that's basically it. So very surprising that these other conditions that you would expect to increase mortality didn't. At least they didn't reach statistical significance of 95% sure that they were right. 95% they were sure. And if you do research, that's p-value is equal to or less than 0.05 if you're into statistics and probability. These all reached significance at the 95%. P equals 0.05 or less. 95% sure these results were right. So multilobular infarctions, lymphopenia, bacterial co-infection. Of course, if you treated that early, presumably that makes a big difference to that. Current smokers, former smokers even, people with high blood pressure and older people. Kind of encouraging, really, in a sense. I mean, these ones are the way the disease progresses, those ones. They're just the way the disease progresses. But these ones are age and lifestyle factors. So one of the things I'm particularly worried about is that this is going to affect young children disproportionately. And it appears that it's not the case with general viral pneumonias. We found out that it wasn't the case with SARS. So personally, I'm hopeful that it's going to be the case that young children aren't as badly affected with novel coronavirus. So that's what the research shows. They are the indicators of more probable mortality with that kind of rating score. So let's have one good news. Children are probably less likely to be badly affected with novel coronavirus. The bad news is it's still spreading and unfortunately, in my view, will become a pandemic.